Well, thank you very much for this really kind introduction, and please accept a million apologies from my side, as I would have planned to be, of course, in person with you in Bangkok. And my last fit time I was there was in 2014, so I really looked forward, but I had some very unexpected and very annoying travel issues. But luckily, Zoom can at least make me a little bit present with you. Um, so it's an honor for me to present here about personalized medicine for pediatric ARDS. And you should see my screen now if about personalized ventilation in pediatric ARDS. And these are by conflicts of interest to disclose. When we talk about mechanical ventilation, we can make it very simple. In the end, it's about inflating the balloon and keeping the balloon inflated. But the question is, how to what extent inflate the balloon and to what extent keep the balloon inflated. And the interesting thing is, and I know this is a little bit provocative, but if you walk around in the intensive care unit, I think it's fair to say that each intensivist is a maven and a savant and knows the only correct way to ventilate a child. But I would like to challenge that assumption. Now, if we talk about pediatric ARDS, we have to go back to the original description of acute respiratory distress syndrome done by David Ashbaugh, at that time a surgical resident, published in 1967 in The Lancet. And together with colleagues, they described a cohort of 12 patients with acute respiratory failure, of whom 2 children, one 11-year-old child and one 18-year-old child. And at that time, the treatment was ventilation, giving oxygen, giving PEEP, and giving steroids. And surprisingly, 60 years later, this is still what we are doing. For years in pediatric critical care, we heavily relied on the adult-based definition for ARDS. So we used initially the American European Consensus Conference, then we used its revision, the Berlin definition. But in 2015, the first iteration, and just last year, the second iteration of the Pediatric Acute Lung Injury Consensus Conference PARDS definition came out, sharing a lot of similarities with the adult-based definition. So it's within 7 days of a known clinical insult. The pulmonary edema cannot be explained by cardiac failure or fluid overload. But different from our from the adult definition is the chest imaging. So in the adults, it's mandated for the definition of ARDS to have bilateral consolidations on the chest radiograph, whereas for us, for the pediatric definition, it is either unilateral or bilateral, because we know there is a very poor correlation between what you see on a chest radiograph versus what you would see on a CT scan of the lungs. Plus, the way how we interpreted the chest radiograph is, sorry to say, not as good as the radiologist does. Now, what is also different in the pediatric definition than in the adult-based definition is that we make use of the oxygenation index or the oxygen saturation index instead of the PF ratio. So the adults only have the PF ratio, but for the PF ratio to be calculated, you need an indwelling arterial line, and this is not common in our patient population. The oxygenation index is a metric that is calculated by mean airway pressure times FiO2 divided by PaO2, and the oxygen saturation index substitutes the PaO2 by the SpO2 if you don't have an indwelling arterial line. It can be used for invasive, non-invasive ventilation, and we have, so on the initial diagnosis, okay, this might be PARDS, and then stratify 4 hours after initial diagnosis in either mild, moderate PARDS or severe PARDS based on the OI or the OSI. And in this iteration, there is a flow chart depending on does your patient meet criteria for age, timing, origin of edema, chest imaging, what kind of interface are you then using, and then depending on the oxygen criteria, you could have either PARDS or at risk for PARDS or possible PARDS. So it really helps to distinguish the bedside physician, okay, what am I dealing with? Now, the thing is, if you summarize all the available evidence and that's what PALIC 2 did, and tried to come up with practice recommendations, we have to conclude that there is no evidence, or a very low certainty evidence, or a low certainty of evidence for most of the recommendations done in the PALIC 2 definition, driven by the oxygen severity. And this is because there is a problem, and I will tell you what this problem is. Ever since ARDS was identified, or the label ARDS was designed, there was already some criticism towards this. And John Murray, who was known for the Murray lung injury score, already published in 1975, well, we need to dissect ARDS. And challenging Art Slutsky and Jean-Louis Vincent said, well, we never see a patient with ARDS. And Martin Tobin, also known for his very provocative editorial, said, well, for doctors at the bedside, none of the revisions of the ARDS definition have actually enhanced patient care over that using of the original description by Ashbaugh. Ventilation, oxygen, steroids, PEEP. So it's important to understand that PARDS is a syndrome and not a disease, and that there is no uniform treatment, and that we need to move away from the one-size-fits-all approach with PARDS. And this is some old work from one of the fellows that was done in one of my previous units. In the pediatric intensive care unit, we are not that good in labeling something PARDS because we label it as the underlying diagnosis. So instead of saying, okay, this is ARDS, we say, no, this is a pneumonia-induced acute respiratory failure. So we, as pediatric critical care practitioners, are actually already doing what Martin Tobin is recommending. We want to identify the underlying cause. So we need to unpack. And I think these two images, the same images from the universe, from the sky, on the left made by the Hubble telescope, everybody was cheering, oh, we can get a good look at the sky. Look at all those stars and look at all those bright lights. But now we have the Webb telescope, and now we understand that all these lights that look very similar are in fact very, very much different. And this is exactly what's happening with pediatric ARDS. It's not one uniform syndrome. And there are some factors that we need to consider, because, for example, if we talk about mortality in pediatric ARDS, we really need to dissect, okay, how much of the mortality is due to what we do in the ICU, low tidal volume, giving PEEP. So what is the syndrome attributable mortality risk? But how much of the mortality is attributable to the underlying condition, so syndrome-independent mortality risk? So, for example, major trauma, malignancy. So the mortality of these conditions affect the total signal of mortality. So this is something that we really need to understand when we review the concept of mortality, for example, in clinical trials. Do patients die from PARDS, or do they die with PARDS? Another important factor why we need to dissect PARDS is so-called heterogeneity of treatment effect. Heterogeneity of treatment effect means that you have patients, let's say a critically ill patient or an ARDS patient. You put this patient in a trial, you randomize the patient to a specific intervention, let's say, for example, a higher PEEP level. Well, in some patients, there might be a benefit, but in other patients, there might be harm. And same for patients with low PEEP level. Some might benefit, some might harm. But then overall, because this heterogeneity, the signal is negative. There is no difference in outcome. And this is what's been going on in many, many trials. And this is what is so-called heterogeneity of treatment effect. So because we pool all the patients together and we do not understand which patient might actually benefit from a specific intervention, you dilute the signal. And this is mainly driven because of the interaction with subphenotypes. And the more heterogeneous a study group is, the more heterogeneity of treatment effect there is. So, for example, if you do a pragmatic trial where you include all your subjects, you have a lot of subphenotypes, so you end up with the risk of having heterogeneity of treatment effect. And John Leffy and Brian Kavanagh really emphasize this in their editorial, trying to explain why so many trials in critical care medicine have negative results. And it's often said, well, the numbers are too small. But in fact, what most happens is that the intervention that's being studied is not matched to the patient. So the biological target is absent. So we need to enrich our studies. So, for example, if we want to do a trial where we want to study the effect of higher PEEP, we first need to introduce some metric of, okay, has this patient a lung recruitable disorder? They said, and I think this is a really nice sentence, designing RCTs as pragmatic might sometimes imply that the underlying biological mechanism of action is not central, which is of course not the case. We do need to understand the biological mechanisms. We do need to understand what is going on. Now, I'm going to show you some examples why this is important. Let's go back in time. So we had the description of ARDS by David Ashbaugh. And then in the 1960s, our knowledge of how we ventilated in the intensive care unit came from the operating room, because the ICUs were in the early beginning primarily designed and driven by anesthesiologists. And at that time, it was advocated to deliver large tidal volumes because they protected against hypoxia. Shallow tidal volume would lead to atelectasis and increased shunting. And this practice resulted in practice recommendations stating, well, you should go for 10 to 15 ml per kg. And we've used it safe in thousands of patients. And there is no evidence of pulmonary damage. And please stay away from low tidal volume. But at the same time, when these recommendations were made, papers came out saying, well, we might consider prophylactic tube thoracostomies because we see so many barotrauma in our patients. And then our understanding of what was going on with ventilation and ventilator-induced lung injury became with this seminal paper from Webb and Tierney, rats that were ventilated with high inspiratory pressure without the presence of PEEP or low inspiratory pressure. And especially in those with a high inspiratory pressure, you see a very serious lung injury. The lung became edematous, hemorrhagic, and the structure of the lung is completely gone. Adding PEEPs protected to a certain degree. And then over the years, in the 60s, when the concept of barotrauma was introduced, for which they said we need to insert the prophylactic tube thoracostomies. And when we were trying to optimize arterial blood gases, we wanted to have normal blood gas in the ICU. Our knowledge woefully expanded, introducing voluotrauma, biotrauma, doing trials with negative results. And now we understand that it's about energy, and it's not about ventilator-induced lung injury, but also about patient self-inflicted lung injury and ventilation-induced lung injury. And our ventilators become even more and more complicated. So we started with negative pressure respirators, especially in the polio epidemic. And then in the 1950s, we received positive pressure ventilations, only volume controlled, no PEEP. And they were further expanded into the 1970s, but again, only volume controlled ventilators. High frequency was introduced in the 1970s. We get more sophisticated ventilators in the 80s, now also offering pressure controlled ventilation. To fourth generation ventilators like the Avia and like the Servo, and now having closed loop ventilation, proportional ventilation. So it's getting more and more complicated. And ventilation, we said in the beginning, it seems simple, inflating the balloon, keep the balloon inflated, but it's getting more and more complicated. We need to beware of ventilator-induced lung injury. We need to beware of patient self-inflicted lung injury through various mechanisms. And we need to be aware of the injurious effects of ventilation on the diaphragm and other respiratory muscles. And then even in the PEDS field, we might be even more challenged because there might be difference between children and adults. When I was in Art Slutsky's lab in Toronto in 2012, we reviewed all the available experimental literature comparing pediatric with adult experimental models, and found striking differences in how these pediatric animals responded to supraphysiologic tidal volume. It seemed less harmful in the pediatric models than in the adult models. There was a difference in surfactant production. There was a difference in the immune response, less pro-inflammatory and more anti-inflammatory cytokines. There was a difference in the structure of the tissue itself, elastin, collagen, and difference in how the vascular system responded. So it makes it even more difficult to understand what's going on in the context of the developing lung. But we do need to improve and adhere to lung protective ventilation bundles. I think this is a very nice study from the PARDS study. The PARDS study was the large pediatric observational study following the publication of the first PELIC definition, exploring, okay, how many patients do have PARDS according to a new definition, how are we managing these patients? And what this study really nicely showed was that we don't adhere to the tidal volume recommendation. So they quantified lung injury using a so-called delta pressure, which is PIP minus PEEP, indicating that the higher delta pressure, probably the sicker the lung was. And what we found was that the tidal volume more or less stayed the same, somewhere around 7, whereas you could expect that with a more sick lung, we would deliver a lower tidal volume. Same goes for delivering of PEEP. They explored how PEEP setting was done in the context of the ARDS network PEEP FI2 grid. And we know, and this should be recognizable for you as well, that at an FI2 of 0.6 or greater, we tend to not increase our PEEP, but accept our higher FI2 with inherent detrimental effects. And all of this non-adherence to lung protective ventilation principles was associated with increased duration of mechanical ventilation and higher mortality, especially in those with severe pediatric ARDS. Now let's go a little bit more in detail why we really need to dissect, because if we look, for example, at the ARDS network trial that was published in 2000, and everybody knows this trial, it's one of the most cited trials in pediatric critical care medicine and in adult critical care medicine. Adults with ARDS randomized to 6 ml per kg versus 12 ml per kg, which was at the time considered to be a normal tidal volume, and there was a strong mortality benefit in those randomized to low tidal volume. But the interesting thing is that this was mainly among those with a low static compliance. So those with sick lungs, stiffer lungs, had the most benefit of a low tidal volume strategy. And in fact, if you go back to how patients were ventilated prior to randomization, the bedside team was already considering the lung compliance. So the lower the compliance, the lower the tidal volume that was prescribed. I mean, it's values that we would nowadays strike us as way too high, but in the end, at that time already, people were looking at lung compliance. And what was interesting, if you stratify the patients by their baseline lung compliance and look at and examine the patients with a high baseline compliance, those randomized to 12 ml per kg, they did fine. Those randomized to 60 ml per kg, they experienced increased mortality, and vice versa for the low compliance group, of course. So having a relatively well-preserved compliance, giving low tidal volume, made higher mortality in those subjects. So the question is, how low is low tidal volume and how should we assess it? This is a nice CT study from adults with ARDS, ventilated with 6 ml per kg from the David Mello's group. And they performed CT scanning in the adults. And in a subgroup of adults, 6 ml per kg was a safe value because there was no end inspiratory regional tidal hyperinflation. But in another group of subjects, 6 ml per kg still resulted in injurious end inspiratory regional tidal hyperinflation. So these patients should have been prescribed a lower tidal volume. And this is completely in line with the baby lung concept from Gattinoni. And Gattinoni stated, the sicker the lung, so the lower the compliance, the stiffer the lung, the lower the percentage of expected normal lung volume would be. So instead of normalizing to body volume, we probably better need to normalize to this amount of inflatable lung volume. So sick lungs with a relatively well compliance can expect a larger tidal volume, and those with a severe compliance, a smaller tidal volume can be given at a given pressure. And despite the fact that this is physiology and seems obvious, we still need systematic reviews like this one from Euban Gallagher and Marcelo Amato, amongst others, published in Blue in 2021, again pooling the adult trials that compare two different tidal volume strategies. And again, underscoring that the effect of low tidal volume on the absolute risk of death is only among those with a high elastance, which is a low compliance. So from that perspective, I don't understand why in the presence of lung injury, we still use modes that require volume setting And I know, for example, PRVC is the very much fancied in the pediatric critical care unit, but I don't understand why we use it because we don't know what the tidal volume is. Now, what do we have for children on this? Well, the problem is we don't have randomized controlled trials. We only have observational data. And if you pool all the observational data, there is not a single threshold of tidal volume associated with injury or different strategies in patients with or without PARDS. Now, this study does not mean that we should not care about tidal volume. I think this systematic review is a very nice example of the heterogeneity that we see in our units, and that we cannot identify a single tidal volume threshold. Now look at the pressure. Let's go back to the ARDS network trial. Because we all have these magic numbers of 2832 in all recommendations, including the PELIC recommendations, and these numbers actually come from the ARDS network trial. If you look at the randomized groups, low tidal volume, high tidal volume, day 1, day 3, and day 7, in those with low tidal volume, the plateau pressure was below 28 centimeters of water, and in those with high tidal volume, it was way above 32 centimeters of water. So this is where this magic number of 28 comes from. So from a bedside perspective, you would ask, okay, how then should I scale my tidal volume? And I think Marcelo Amato answered this question for us by introducing the concept of driving pressure. So we know lung strain is the ratio of volume over n-expiratory lung volume. For the baby lung concept, the n-expiratory lung volume is linear related with compliance. So if we substitute n-expiratory lung volume by compliance, we get driving pressure, which is the ratio which is a change in volume over the compliance. And what Marcelo Amato did is he pooled the adult trials, did sophisticated statistical analyses, matching a group for PEEP, matching a group for driving pressure, and matching a group for plateau pressure. And in the group that was matched for PEEP, increasing driving pressure was associated with an increased risk for mortality, whereas decreasing driving pressure by limiting the plateau pressure to 28 and increasing the level of PEEP was associated with a decreasing driving pressure, so a decrease in lung stress. So you could say, as long as my driving pressure is below a certain value, if my tidal volume is somewhere between 4 or 8, I'm fine. I don't need to find a specific number for my tidal volume. I need to see it in the context of driving pressure. And driving pressure is also an important variable in children. We try to mirror the analysis that Amato did in a group of 300 children with acute respiratory failure, try to find them for direct and indirect pulmonary indication, doing the same analyses. And especially when we matched for PEEP, we also saw that a increase in driving pressure was associated with a decrease in ventilator-free days, with probably a threshold of about 15 centimeters of water, similar to the number that was reported by Marcelo Amato. Now, the problem with driving pressure is that it ignores the chest wall, and this is a slide that I showed yesterday in the workshop as well. But here I have two patients, both with a similar elastance, so a low compliance. But in one patient, this is mainly due to a pulmonary ARDS. The lung is very stiff, whereas the chest wall is relatively soft. And in the other patient, the elastance is partly coming from injury to the lung and partly coming from injury to the chest wall. For example, an obese patient or a patient with edema or a patient with chest trauma. So we need some measure to account for what the chest wall is doing. And this can only be done by esophageal pressure manometry. Because we know driving pressure, we can easily calculate it by plateau pressure minus PEEP. It includes the effect of the chest wall, but you can see, for example, here you have a patient with a high alveolar pressure, but with a very stiff chest wall, the pleural pressure 25, so the transpulmonary pressure is only +5, which is not that injurious. And same for example, for a trumpet player. A trumpet player generates an alveolar pressure of 150 centimeters of water, but this trumpet player doesn't get ARDS because the pleural pressure is very, very high, again leading to a modestly transpulmonary pressure. And we know that there is a not so good correlation between the airway plateau pressure, so what we measure from the outside, and the actual transpulmonary pressure. So we need esophageal pressure manometry. If we want to talk about this PEEP issue, because we talk now about driving pressure and volume, if we want to talk about the PEEP issue, it becomes even more and more complicated. The adults thought they were smart, and ArtsNet developed two grids, a low PEEP high FI2 grid or a high PEEP low FI2 grid, easy to use at the bedside, stating, for example, okay, if your FI2 is 0.5, your PEEP should be either 8 or 10. Now, these tables are not related to physiology, have not been validated. It's a consensus approach. And this probably explains why, if you look at if you examine the adult trials comparing two different PEEP strategies, overall, there was no effect on survival. In ARTS trial, in the LOVES trial, in the EXPRESS trial, and even, for example, in the most recent trial, the R trial, where higher PEEP was combined with lung recruitment, there was a higher mortality in those with lung recruitment and higher PEEP levels. And this is probably, they didn't assess the potential for lung recruitability prior to randomization. Because if you review one of the tables that is in this paper, in those randomized to the lung recruitment high PEEP group, there was a higher prevalence of pneumothorax requiring drainage and a higher prevalence of barotrauma. So the intervention was applied to all subjects, but in this group, there might be subjects that might have benefit from higher levels of PEEP and those who might not have benefited from higher levels of PEEP. And that is very nicely exemplified by this paper from Jean-Jacques B, showing two patients, one patient with a diffuse ARDS, one patient with a focal ARDS. In both patients, PEEP was increased, leading to an increase in lung volume, as you can see from this cartoon. But then if you look at the Hounsfield units, and the more negative, the more overdistension, in the patient with diffuse ARDS, increasing the PEEP resulted in a better aeration, but in the patient with focal ARDS, increasing the PEEP resulted in a significant degree of injurious hyperinflation. And this cannot be seen from the outside, and this cannot be counteracted when you apply the grid, because you would have applied the same level of PEEP in these patients. Again, dissecting the syndrome. Now, Daniel Telmore tried to show that esophageal pressure manometry and then guiding PEEP based on esophageal pressure manometry measurements would be beneficial. And in the first study, they looked at lung mechanics, so it was a more feasibility study. And indeed, if you set your PEEP based on esophageal pressure manometry, there was a better oxygenation, a better compliance, because higher levels of PEEP were used. Without increasing lung stress, the plateau pressure stayed below 28 centimeters of water. Fortunately, in this follow-up trial, there was no effect on patient outcomes, so mortality was comparable between the two groups. But again, I would argue that this is not that PEEP-based, that esophageal pressure-based PEEP titration doesn't work. It's probably because all patients were pooled and there is strong heterogeneity of treatment effects. And I think one of the studies that really underscores the need for dissecting is this reanalysis of the EXPRESS and the LOVES trial. If you look at the adjusted probability of death and the change in PF ratio following initial PEEP modification, so in those where the PEEP was increased, if there was a increase in oxygenation, there was a lower risk of death. So change in oxygenation could be used as a entry metric for a trial. Say, okay, I do a recruitment and the patient doesn't benefit from oxygenation, then probably I shouldn't put this patient in a PEEP trial. So again, dissecting. Now we can argue that the same holds true for the pediatric trials that are out there. So we have, for example, the PRONE trial for Martha Curley, published in JAMA in 2005. Children with acute lung injury were randomized to prone position or supine positioning. And as expected, the oxygenation improved, PF ratio improved in subjects randomized to supine, and the OI improved. But overall, there was no difference in ventilator-free days between the supine and the prone group. And again, this probably can be explained by the fact that all patients with acute lung injury were entered in the study, and not those with either severe or with potential for recruitability. And the adults experienced the same, because initially proning trials in the adults didn't show a positive effect on patient outcome. But when all these results were pooled and then stratified for the baseline severity of the ARDS using the PF ratio, then the strongest signal was seen in those with severe ARDS, so the PF ratio below 100. In that group of subjects, proning had a significant effect on patient outcome. Same goes for high frequency auscultatory ventilation. So you all remember the high frequency trial published in 2013, the Oscillate trial. And this Oscillate trial was prematurely stopped by the Data Safety Monitoring Board after the inclusion of 550 patients, because there was an increased harm in those randomized to high frequency. Death in hospital, death in the ICU, and death before day 28 was significantly higher in the high frequency group. But again, this was because the approach to high frequency was standardized in this group. And in particular, the recruitment maneuver was standardized in this group. So what they did was a so-called sustained inflation. The idea was you were randomized to high frequency, they would recruit the lungs by applying 40 centimeters of water for 40 seconds and then return to 30 centimeters of water. But if I display two patients in this slide, and these are the pressure volume loop, this is a patient with his ARDS, and let's say the pressure volume of this patient is over here. Applying 40 centimeters of water for 30 seconds, and then ending up at a one-size-fits-all approach of 30 centimeters of water would result in a significant overdistension and causing hemodynamic compromise. Whereas in a patient with very, very, very bad lungs, or with very, very low compliance, doing 40 centimeters of water for 40 seconds and then returning back to 30 centimeters of water would result in a significant de-recruitment. And we have shown this, not really shown it, but we have explored the potential for lung recruitability in children who were managed with the oscillator. So we did a staircase incremental decremental mean air pressure titration, normalized the pressures so that we compared the whole group and quantified the change in lung aeration using respiratory inductance plethysmography, which are these two bands. They measure the cross-sectional change, and you can imagine that if the cross-sectional change of the chest expands, that's probably because there is more volume. But as you can see, especially at the higher pressure ranges, there is a strong heterogeneity in how a patient responds to an increase in mean airway pressure. And there's also not a clear lower or upper inflection point. So you can imagine if you would apply 40 centimeters of water in for 40 seconds, back to 30 in these patients, there would be a very strong heterogeneous response. So it's really important to dissect and to really subphenotype a patient with pediatric ARDS. And we were invited by Lancet Respiratory Medicine to prepare a narrative review paper on this, about understanding clinical and biological heterogeneity. And the concept that we propose in this paper is that, well, you have this heterogeneous cohort of children, acute respiratory failure. We have them either on high flow nasal cannula or on non-invasive ventilation or on invasive ventilation. We first assess for PARDS based on our pediatric criteria, but then we still have a heterogeneous cohort of children. So the next step would be to identify subgroup based on demographics, lung mechanics, inflammatory profile, underlying disease, whatever means. This is something that is area for future research. And only then we identify which patient cohort might actually benefit from our ventilator management. We can apply individualized ventilation and management, individualized treatment and escalation to second-tier interventions like high frequency or ECMO. And this is really, really fascinating, because there's more and more data coming out that this is really the way to go This is adult data, but this is a fascinating study from Michael Mattei and Carolyn Calfee, where they had a biorepository of patients who were enrolled in two large trials. And they did a latent class analysis measuring all sorts of mediators and other variables. And then they found that there were two distinct phenotypes, a hypo-inflammatory phenotype and a hyper-inflammatory phenotype. And that the difference in phenotype corresponded with specific interventions and the clinical expression of these patients. But even more interesting, there was a difference in outcome in the two phenotypes. So the hyperinflammatory phenotype had lower organ failure-free days, had lower ventilator-free days, had a higher mortality in both cohorts. But there was also a difference between the phenotypes in how they respond to a specific intervention. If they explored low versus high PEEP and they compared phenotype 1, phenotype 2, and especially in the hyperinflammatory phenotype, the response to higher PEEP was beneficial. So there were more ventilator-free days and more organ failure-free days and lower mortality when patients with a hyperinflammatory phenotype were randomized to a higher level of PEEP. So the phenotype that you are having drives the response to a specific intervention and ultimately drives your outcome. This is also in children. We don't have intervention trials, but we do know that these phenotypes, the same phenotype as in the adults, exist in pediatric ARDS. This is from the biorepository of the RESTORE study done by Mary Damer and Heidi Flory. Same phenotypes, and very nicely shown that especially in severe PARDS, there is a predominance of the hyperinflammatory phenotype. Now, one of the trials that is going on is the PROSPECT trial, of course, the Prone and Oscillation Pediatric Clinical Trial funded by the NIH, one of the largest funded studies in the pediatric field so far, $15 million funding to address two specific aims: to compare the effects of prone versus supine on ventilator-free days and to compare the effects of high frequency versus supine on ventilator-free days, testing the hypothesis that children with high, moderate to severe PARDS, that's already a bit dissecting, treated with prone or high frequency will have more ventilator-free days. And we not only limit to the high, moderate, severe PARDS, but we further try to address heterogeneity by stratifying upon randomization for age, as there might be a difference in response, and by type of lung injury, direct versus indirect, as there might be a different response. And it's very much individualized because the approach to ventilation in both arms is very much done by individualized titration, in particular for how we set the PEEP and the mean airway pressure. So if we were to summarize the personalized medicine for PARDS, an individualized lung and diaphragm protective ventilation, phenotype, what kind of patient am I seeing? If we look at the pressure volume loop of this patient, inflation limb, deflation limb, and we know that the safe zone of ventilation, so the place where we can only safely ventilate, is a very small part of this loop. We don't want to ventilate at high lung volume, being injurious. We don't want to ventilate at low lung volumes, as is being injurious, areas that are aerated and non-aerated. So we want to scale our tidal volume to the aerated lung tissue by doing this to the driving pressure. We want to titrate our PEEP, balancing oxygenation and hemodynamics. And by doing this, we reduce lung strain. We limit our plateau pressure. We limit our driving pressure. And by doing this, we limit our lung stress. And there was no time to talk about that, we measure transpulmonary pressure and we measure mechanical power, as mechanical power is an integrative summary of all the components of ventilator-induced lung injury, and assess potential for lung recruitability. So really individualizing what is going on in our patients. So pediatric mechanical ventilation for PARDS, but actually for pediatric mechanical ventilation in general, needs to be individualized, making use of physiology-based concepts such as driving pressure, mechanical power. Titrate ventilate settings to the degree of respiratory effort. And always ask yourself the question, what does this individual patient need at this moment of time in the disease trajectory. And we do need randomized controlled trials, obviously. And I'm a big fan of having them designed as explanatory trials because we need to understand the biological mechanisms. We need to not only understand if an intervention works, but also how an intervention works. And this means that we need to enrich our trials. We need to assess physiological responsiveness before we test patients with an intervention. And by doing that, we can improve the signal to noise ratio. I hope to see you all in a few weeks in Rome at the ESPNIC meeting. And I hope I will be able to come to Bangkok anytime soon to really meet you in person because I'm really sorry that I'm not there in present. And with that, I would like to thank you very much for your attention and happy to answer any questions.